The management of neuroendocrine has changed a lot in the past few years, and it's actually a wonderful improvement. Basically, what we've done is increase the number of tools in the toolbox. So in the past, we had surgery, of course, was very important. And of course, we had shots that we would give, synthetic hormones. But in the past few years, we've seen a lot of new innovation. They include medicines, which we can use to help slow down the growth. We have new chemotherapeutic agents that help. We also have some new agents that can help patients with their symptoms. So people, for example, who have very severe diarrhea can have other medications we can help. But the really new medication that we've tried, that we've included in the toolbox, is something called PRRT, or peptide receptor radionuclide therapy. It is a new type of treatment which combines the hormone with radiation. So now you can get liquid radiation therapy from the inside out. And all of these treatments, which were available outside the US previously, are now available here. And so it's given our patients many more options to hopefully have a better quality of life and quantity of life. With these new tools that we have, it actually becomes more complicated. Now remember, neuroendocrine is a different type of disease. It's a different kind of cancer. It's a chronic cancer. In general, they tend to grow very slowly. Now there are versions that grow very fast and can be very deadly, which is a different type of thing. But with our more well-differentiated or slower growing neuroendocrine cancers, we have to think of it differently. We have to think of it as a marathon and not a sprint. Again, the great thing is we have lots of tools in the toolbox. Some innovations that we've seen have been in imaging, for example, where we have this new scan called a gallium dotatate PET scan. That has changed the way we take care of patients because now we can see the disease so much more clearly, and we have a true and very accurate evaluation of where the disease is. But then once you know what you're dealing with, which is absolutely important to start out with, now you have to decide what you want to do. Because we have so many tools in the toolbox and every individual person is so different, you want to make sure that you provide the right care, know what's needed, and in addition, sequence it. So there's a lot of thinking that's involved with taking care of a neuroendocrine patient. For example, sometimes patients really have a lot of symptoms because their stomach hurts. Maybe their bowel's obstructed. In that case, then that patient needs surgery. Sometimes they have tumors that can be removed surgically. That's great. So we try to do as much surgery up front. But sometimes the disease is spread very, very far and they need more systemic therapy. In those cases, we would want to make sure that their whole body is treated. And our first line is always a somatostatin analog, which is a synthetic hormone we use. But then there are other treatments that we can add, different medicines. And of course, in certain cases, you may want to give this PRRT liquid radiation therapy sooner than later. So there's a lot of thought that goes into it. And sometimes, if the disease is just in the liver, you can even do different types of embolization to the liver, which is more of what we call a local regional therapy. And then you can just treat the liver. The problem with neuroendocrine is it's very complicated and there's no pathway for treatment. It's more of a web of treatment. And so seeing a neuroendocrine specialist is very, very important to help make those crucial decisions.